I'm going to stop sharing, but I will, just prior to doing that, introduce our presenter for you now. So Qorinah Adnani is an assistant professor of midwifery at the Department of Public Health, Faculty of Medicine at the University of Padjadjaran in Bandung, Indonesia. She is chair of the Master of Midwifery program and lead of the Midwifery Working Group at the Faculty of Medicine. She has a career spanning more than 19 years as a midwife and lecturer in midwifery, and she earned her PhD in midwifery from the Auckland University of Technology in New Zealand. In 2023, she served as a visiting scholar in the Department of Midwifery at Yale University School of Nursing in the United States. So without further ado, I will stop sharing and I will allow you to share, Qorinah. Please welcome Qorinah.
Okay, thank you so much, Kate, for your kind introduction. Can you hear my voice?
Yes, absolutely.
Okay. Wait, can you take a look my slide now?
Yes, I can see that one.
Okay. Okay. Thank you so much to everyone to joining us today to the prestigious event to celebrate the International Day of the Midwife. And I'm truly honored to be invited as one of the keynote speakers. And this theme sits very close to my heart, that I want to tell about the experiences that we have related to the bridging the gap between the midwifery education and practice in Indonesia. So when we talk about Indonesia, so probably the majority of the participant from Indonesia, but we also have the international participants now, and probably may not the complexity about the Indonesia. So Indonesia is one of the largest archipelago in the world, and we have more than 17,000 island with population. I think this is previous statistic that we have more than 200 million population with high diversity. So we have like more than 300 ethnicities and languages across the country. So our earlier study reveals the complexity that there is socio-economic development. We have still like inequity and about housing, the health development, transportation, health facilities, that because we have this complexity of the country. And when we take a look about the current statistic on the maternal mortality in Indonesia, we have a maternal mortality rate 189 per 100,000 live births. And based on the national data, that Indonesia already reported like more than 4,000 maternal deaths in 2020. And in 2021, this statistic increased by more than 7,000. And it means like more than 50%. And when we take a look the target of the Sustainable Development Goals by 2030, we need to reach like around 70 maternal mortality rate per 100,000 live births. So it's quite striking when we take a look this statistic, and actually most of these maternal deaths could have been prevented with timely, quality, and respectful maternity care. Because based on our qualitative study with bereaved family, we have like not only now 3 delays of the maternal mortality, but we found 4th delay that related to the digital barriers around this maternal mortality. And the current evidence reveal that the strongest pathway related to the timely, high quality, and equitable maternal care is midwife-led continuity of care. And we agreed about the general terminology about what it means of the midwife-led continuity of care. And this is what's happening in Indonesia, what we already found, and we have more than 400,000 midwife registered in Indonesian midwifery of health at the moment. But due to all the islands and the complexity that we can see from the image itself, how difficulty of the midwives if they work in a very rural area. So midwives probably when they are working in Jakarta as the capital city of Indonesia, for sure they will having a difficulty and barriers quite different with like for example midwife who work on the very remote area in Indonesia. And if so, they also struggle to find the appropriate time for their education. Even as we know, midwives are the backbone of our maternal and child health care. And based on our recent study itself, when we talk about the midwifery continuity of care, because this term itself is quite new with our medicine colleagues. So because most of my time working under the faculty of medicine, so when this study proceed under our university, we found very compelling evidence about how this midwife-led care works in low middle income countries. Even we need more research about this, but this what we found that related to the review on how midwifery continuity care works in low middle income countries. And we continue the conversation about the continuity of care if only possible when a midwifery education equips for sure like a midwifery graduates about the competence and confidence during the continuum of care. So probably for the participant who not know about how our midwives educated, so this is also based on our study that talk about the decoding of the newly graduated midwives and how midwives educated in Indonesia. We have this specific framework about vocational, academic, and professional midwifery program. And we also have bachelor, master, and even not specific doctoral in midwifery, but most our doctoral degree program, they can continue with specific midwifery topic with the faculty of medicine. Once they complete it, they need to take the national competency test, and once they complete it, they will become associate midwife and midwife. That's quite a differences between vocational and professional midwife. And at the moment, across the country, we have more than like approximately. It's not the fixed number because it's quite mobile for the number, but around this more than 700 across the country midwifery school. And specific for the vocational and professional, we have a balance that the 60% theory and 40% clinical practice. So during their classes, they need to do tutorial, mini lecture, and then project-based learning, student-centered learning. They took a computer-based test, student oral case analysis, and for the laboratory, they also need to do the lab act and then skill lab, objective structure, clinical examination, and then clinical placement as a mini clinical evaluation exercise. But I want to underline that the majority of those 100 of midwifery school not really follow this specific terms of what they educated. But generally, they have to do that. So that's why when we found, this is also based on our previous study about the midwifery education and what we found related to the clinical practice and how there is a theory and gap related how we need to enhance hands-on clinical skill about the mentorship, guideline learning, and the specific bridges the theory and gap and how the clinical practice environment to build the competency across the students when they do practice. And also what we found on the ground where there were limited hands-on access. So midwifery students often just do the observation rather than they did it as an active participation due to the high competition to get the cases for in the clinical setting. And then specific about how when they thought at the school and how the actual practice as the clinical environment. And also about the mentorship challenges, we also have found that they often lack a specific training and they also overburdened with client loads at the specific clinical setting. And overall, for the systemic concerns, the clinical environment also often prioritize medicalized hierarchy over midwifery-led continuity models. So we continue trying to how we bridge the theory and practice by integrating continuity of care into the midwifery curriculum or our midwifery curriculum by this specific 4 pillars when we trying to refresh the midwifery curriculum in our midwifery school. So we try to do this specific thing and also trying to build the continuity of care mobile app. And actually this is funded by the collaboration Research of Indonesia and part of the partnership with more than 2 universities in Indonesia trying to build mobile app by, as I mentioned earlier, about the workload of the mentor when they deploy by the midwifery student. So we try to reduce the workload either students and mentors by develop this and trying to digitalize what they need to report as a students. And also Probably we may have paused when from the previous study that we conduct when the midwifery students state that we were only allowed to observe. There were so many students and the midwives were too busy to guide us. How can we be confident if we never touch the patient? So that's the concern of our current midwifery student when they raise this kind of specific issue about the hands-on experience. So that's why when we continue our research about what it takes actually to build the self-confidence and competence across the midwifery students and how to make sure they graduate confidently and competent. So they said that there are this kind of specific 4 pillars that related, that simulated practice. And then interestingly, when we conduct this study across the undergraduate student, they also state about the research engagement. That's very interesting when this came up from the undergraduate student rather than master student, and then independent learning and active discourse. So, and also what we are trying to do about how we try to bridge the gap between the midwifery education and practice, we try to like establish what we call it. So Ruang Bidan Indonesia, it means like midwife space of Indonesia. So now it become the foundation, and I'm so blessed to become the chair of this board of the foundation, because when this foundation established, it is served as a collaborative space where midwives, either they, not only midwives, I mean like everyone who are keen to support, learn, grow, and connect under our spirit, becoming a midwife with heart, together to do what we are trying to develop. And since 2020, we already have this program and then milestone that we are trying to build. And now we already gathers, because it's still like based on the voluntary stuff, and we run out the fund. So generally we take the fund from the community service organization. But since 2020, we already have this participant come from diverse region, and because this is like a foundation and based on the voluntary work, we have more than 80 volunteers. And we also conduct the academic things that build either to improve the knowledge, skill, and etc. from the more than 9 countries. And we have like more than 100 speakers and also more than 100 events since 2020 until now, and more than 1,000 alumni from this program that we are trying to do part of this term. And if you, yeah, we usually update what we are doing and gather what we can do by the social media. And yeah, probably there are still significant challenges that we are facing at the moment. And when we try build the like a mobile app and then trying to build or establish the foundation, what we are trying to highlight is how we try to bridge the theory and practice across the midwifery education and practice. And I believe this is like the same spirit that we are doing right now as part of the virtual International Day of the Midwives. So I think that's the end of my presentation. And if you want to take a look further about the paper that I share, probably you can take a look here. And yeah, happy International Day, everyone. And I will hand over to Kate. Thank you so much.
Oh, Qorinah, that was wonderful. Thank you so much. That was amazing. I know that there will be people in the room who will be very interested to ask you questions. I'm just looking for my little host tools. There it is. I've just allowed for people to unmute themselves. A big round of applause for that wonderful presentation. Now, would people like to pop their hands up, and I will see who has the first question, or pop questions in the chat, whatever you would prefer. But I know there will be some great questions in the room. My first question for you, Qorinah, is what feedback have you had from students with regard to the mobile app? Have you had any qualitative responses or quantitative response?
Yeah, thank you so much, Kate. As we still develop this mobile app, COC mobile app, and it's still not on the like a Google, how we call it when we display our app to the things, Google Play Store. So we still uh looking for more grant to develop the app. And we receive the positive feedback actually from our midwifery students, how like they can see and do everything through their mobile phone, because usually they have a smartphone, so that's why. But because it's still not on the Google Play Store and still developed, and only like each year we need to like subscribe and get more money to get alive. So yeah, that's quite the challenges due to the fund. But yeah, we received the positive feedback because we also did the mixed methods study around the initiation of this COC mobile application.
Great. We've got
So
a question.
I can share the paper later. Yeah, let me, yeah.
Oh, that would be lovely. We can pop it in the link for everyone, actually. That would be
Yes.
really good if you've got that there.
Yeah.
I can see a question. We've got a question in the chat. How can midwifery education programs be redesigned to better reflect workplace realities in resource-constrained settings, Qorinah?
Um, yeah, th thank you for hard question actually. Um, I'm so sorry if I mistaken to pronounce. Uh, Bupe Wamba. Yeah, greetings to you. As I mentioned earlier, my also PhD related to the strengthening midwifery education while I was doing my PhD in New Zealand, and it's becoming the national debate at the moment about the design of the midwifery midwifery education. I give you the example how it's becoming the hard question, because When I show you the framework of our midwifery education at that moment, we have undergraduate level divided into vocational, professional, and this specific professional, they can be from vocational and academic program. So, for example, vocational now recognized by the Midwifery Act 2019 and revisited again with the current regulation. Actually, diploma 3, so it means like a 3 years of midwifery program. That means vocational. But my university, we have advanced diploma of midwifery program that take 4 years to finish vocational program. But they need to continue the professional midwifery program to become they call it we call it midwife when they finish the professional midwifery program. But commonly uh, generally at the university level they have the academic and professional midwifery program that we call it the bachelor of midwifery program. So based on our like a long history of the midwifery education in Indonesia, what the decision maker trying to do, like based on these midwifery graduates, they can't agile enough to respond and then to capable enough to work in any realities, limited resource constraint settings, particularly in Indonesia, that we call it like remote area. We have a specific terminology for this kind of remote area. So yeah, it's become still national debate actually, Bupe, at the moment, because in our university itself we are still struggling to open the professional midwifery program as part of the requirement to becoming a midwife rather than associate midwife graduated from the vocational program from the diploma of midwifery school. Yeah, I know it's quite complicated things, but I think that's all this decision maker in midwifery uh, thought that this is the best way with dualism of undergraduate midwifery program to answer the specific needs from the limited resource settings in our countries particularly. Hopefully that's answered this hard question.
Yes, that's very fine. Another question.
Oh,
Oh,
okay.
Bupe, good on you. How do staff
Oh.
shortages, high workloads, and poor working conditions affect the transition from education to practice?
Wow, it's also the hard question. Yeah, thank you, Kate and Bupe. And our recent qualitative study that related actually to the how the maternal mortality reporting. mm, it's and also about the workforce paradox. So we did actually I this kind of specific issue about the workforce paradox, how the like comparing the density of the midwife and the maternal mortality. We did it in West Java, and it becoming the poster presentation in the ICM actually, Pupe. So, and we are working on for the paper as well. But interestingly, the issues are related to the density of the midwife, not only the number. So how they deploy, because as I mentioned earlier, we have like more than 17,000 islands, and not many midwives want to be work and deploy at the remote area due to the issue school, housing, access, transportation, and etc. So usually after they did the community service as part of the requirement, they usually leave, and they leave to the more urban area, because like the basic and secondary needs that they want to receive that related to the housing, school, and etc. So yeah, it's when I saw you the previous images, midwives who are still keen working at the urban area, they are indeed a hero who still, like keep their patient to work at very remote area. So yeah, I think like since COVID pandemic, because of the internet and Zoom and very, like many webinar online for free, they usually can catch up with what's happened outside their rural areas. So yeah, it's hard question actually, how how do it and how affect all this kind of transition, because what we found once they finish the community service, they finish it, and oh, okay, we will try to looking for a better, like condition and etc. I will share what I talk about, that probably you can read through what we found in full paper. And for the workforce paradox itself, actually there is a positive correlation when midwife with wife deploy. It's have a positive correlation with the decrease of the maternal mortality. But again, we talk about the complexity of the country, with not only we face the equal stuff in many things, but inequality with the infrastructure access and etc. So yeah, it's not it's not easy.
Another great question coming through. How do societal perceptions of midwives influence education quality and professional practice in LMICs?
Thank you so much, Ube. You throw me a lot of hard questions actually. So interestingly, what we found in Indonesia, even all this systemic hardship, more than 90% women across reproductive age, they coming to midwife to did like for antenatal, in childbirth, postnatal care. So midwives still like on woman's heart in our country. So everything, if they facing health difficulties, the health workers that they want to find are midwives in their village. That's quite striking founding, because they not coming to like another health professional, so they trust and they believe midwives more, because I think like because they are being present, and because probably their quality that they provide, particularly at the villages, and as I mentioned earlier, we have a very layers how we live at the moment, like not only urban and rural areas, but multiple layers people living. So they still trust midwives that related about the community perception. So, for example, if sometimes only they face an accident in the village, they come into the midwife. So that's the proof that our community trusts and believe on midwives more. But uh yeah, about the quality and professional practice, we have what we call it. So the Indonesian Midwifery Association, they also have what they call it delima, so bidan delima. So probably here we have a lot of Indonesian colleagues who joining, so probably also can share their experience about how our midwifery association, other midwifery organization in education and association try to ensure the quality of the midwifery education and midwifery practice through multi layers of the quality assurance. But again, um, when our study found that related to the regulation that needs to be exist, like for example, midwifery council or midwifery collegium, but we are still need to do more about the quality assurance if we talk about the quality of midwifery education and midwifery practice. But yeah, we keep moving forward to make sure that probably that's my response to the Pupe's
That's fine.
questions.
You mentioned trusted midwives in community earlier, and Isabella Gardi has popped a message in the chat and said, that's exactly what I shared this morning in session 3. Trusted midwives provide continuity, monitoring, and listen to women, not just during pregnancy, but well beyond birth, which is really a fabulous comment. Thank you, Isabella. And thank you, Bupe, for those wonderful questions. That was magnificent. We probably have time for one more question. I can see Bupe, would you like the last question there?
Yes, so it's a follow-up question with regards to that, because looking at the society, we as midwives, we can view ourselves, but is everybody out there viewing us in the same lens that we use to view ourselves? How is your relationship, Qorinah, with obstetricians? Are they able to listen to you? And so society means everybody else. I know we value ourselves and, we want every woman to have a midwife, but is that the view of everybody in the society? Thank you.
Yeah, thank you so much, Pupe. That's very thought-provoking question that related about the interprofessional collaboration with another health professionals, and what I can, it's a hard question actually to respond that, because as I mentioned earlier, we are under the faculty of medicine, so it means like I can tell like the majority or most of my colleagues are medical things, and when we talk about the relationship, particularly with the obstetrician, we work together, I mean, in education and in practice. But again, when doing the midwifery staff at the hospital, for example, for sure it's based on the medicalized rather than the autonomy of the midwife. That I can tell probably about the interprofessional collaboration. And what we found actually that related to the another issue is professional boundaries. So it is not easy to say that, but actually we are facing at the clinical practice about the professional boundaries. So for example, I come from the country that when we call people or we call someone, usually we use like ma'am or sir or etc. But when I go to the West world, like New Zealand, for example, it took 2 years for me to call my primary supervisor by her name, like, oh, hi, Judith, rather than, hi, Professor Judith. But when I come back to Indonesia, I need to give those kind of, like specific title when I call like, oh, good morning, doctor, professor, or etc. Because it's also part of the is value in our country. Like it's considered like a rude when we just call someone with the name, like like my student call me, hi Corinne. that's considered rude in our culture. So we are trying about the really hard working on the interprofessional collaboration. And we also establish what we call the course that related to the interprofessional education in our undergraduate midwifery program. So that's what we are trying to do to bridge the theory and practice when we found the professional boundaries. But interestingly, even me, like under the faculty of medicine, the health professional who join this course are coming from nurse rather than from the medicine. So that's interesting thing, Bupe, if we talk further about the interprofessional education and interprofessional collaboration. But yeah, again, we are trying to do what we can do, and I think yeah, I think that's the response that I can share. And I also share the paper that I respond that related to workload of our midwives, and then the continuity of care mobile application that probably everyone can take a look further about this app, and also the workload of our midwives. And related to the workforce paradox, we are still working on it. And yeah, probably if you are going to Lisbon this year, probably I can share it because we'll display on the poster presentation. Thank you so much, Pupe. I hope that's answer your heart